Good afternoon, everybody. Thank you for joining me for session number two, the succession gap, protecting revenue and services in an aging medical staff. So, across the rural healthcare, many organizations are facing a growing reality. A significant portion of their physician workforce is nearing retirement. Oh, nice. But replacing long-standing rural physicians is rarely just a recruitment challenge. Physician transitions often impact referral relationships, service line stability, productivity, access to care, and long-term financial performance. In this session, Claire Kelly, Senior Consultant at Stroudwater, alongside Kevin Durande, CEO of Mahaska Health, will explore how rural healthcare organizations can approach physician succession planning as a part of a broader long term strategic and financial sustainability effort. Drawing from both strategic consulting experience and operational leadership, the discussion will focus on how organizations can proactively identify risk areas, align recruitment with long term service line planning, and strengthen provider development strategies before the critical gap emerge. So thank you very much, Claire and Kelly. Claire, Kelly, and Kevin. I will hand it off to you.
Good afternoon. Thank you so much for joining us. We're really excited to be here to discuss the succession gap, protecting revenue and services in an aging medical staff, and how having a provider strategy or a plan can really help with recruitment and retention. As Amy said, my name's Claire Kelly. I'm a senior consultant with Stroudwater Associates. I dabble in all things rural strategy, specifically provider strategy and partnerships. And I'm absolutely delighted to be joined by Kevin Durande, who's the CEO of Mahaska Health, and will talk to us about how he's implemented a multi-year provider strategy at his organization. So why have this conversation today? Why does having a plan matter to rural hospitals? Well, I don't think it will come as a surprise to many of you that the US is facing a pretty steep physician shortage, with a predicted shortage of up to 86,000 physicians by 2036. Additionally, an estimated 42% of the current medical staff, current physicians and providers, are between the ages of 55 and 64. So we're anticipating that in the next 5 to 10 years, there's going to be a large amount of folks that are retiring or going from a full-time to a part-time basis. What's been happening with that trend is we're seeing that really hit rural geographic areas harder, where it's taking longer to recruit folks specifically in specialties to rural areas. Right now, we're seeing a current recruitment process for specialists range anywhere from 18 to 24 months. So the question is, how do we proactively take steps to make sure these gaps in access to care, if you have folks that are retiring, don't occur? How do you continue to provide services to your community and make sure those services are sustainable? So we're going to be talking a lot about what a provider strategy is and a medical staff development plan today. And we want to start out with being able to define both and show you the unique components of both. And to kick us off, we have our first polling question. How old is your most recent medical staff development plan? Is it less than a year? Is it 1 to 3 years? Is it 3+ years? Do you not currently have a medical staff development plan? Or are you looking to implement a medical staff development plan? And we'll let folks have another 20 seconds or so to respond. There are no wrong answers here. It's mostly just trying to orient folks to kind of where you stand in terms of your planning. We've got answers pouring in. Thank you so much to those that have answered. Right now, 54% do not have a current medical staff development plan. 22% have one that's 1 to 3 years old, 14% 3+ years old, and 2% less than a year old. Awesome. So final numbers are 56% of folks on this presentation today do not currently have a medical staff development plan. 21% have a plan that's 1 to 3 years old, 15 3+ years old, 6% would like to implement a medical staff development plan, and 2% have less than a year old medical staff development plan. So what should a medical staff development plan do? What should it tell you? A medical staff development plan should really simply tell you how many providers, including physicians and advanced practice providers or APPs, your organization needs within certain specialties within its primary and secondary service areas. This is what we like to call the provider complement. This provider complement should outline if these folks should be employed, if they should be through affiliations or partnerships, clinical services partnerships, whether they should be full, part-time, or full-time. Additionally, this plan should look at operational improvements through different analyses such as a productivity analysis by specialty, a revenue analysis by specialty, and throughput per specialty. This is really important when it comes to succession planning, is knowing what specialties are going to be really the key ones to look at in the next 5 years. To get to what we just asked in terms of a polling question, how often should you conduct a medical staff development plan? We typically see best practice is to have a medical staff development plan done every 2 to 3 years. And really, you want to do this in conjunction with your organizational strategic plan. So anytime you're updating your organizational strategic plan, think about having a medical staff development plan, because combined, they can really be effective and you're more likely to implement a lot of the actions outlined in your medical staff development plan. Additionally, we all are facing some pretty serious headwinds in the national healthcare industry. So having a plan that's updated every 2 to 3 years, even though it may project 5 years out, is really important just to staying nimble, as a lot of strategies are shifting right now as we're kind of facing what's coming down the pipeline on a national scale. So the elements listed here are what we would consider the key components of a medical staff development plan and a provider strategy. The medical staff development plan is really all the elements outlined in phase 1 and phase 2 and compose really what we would consider that provider complement. Within phase 1, you're looking at the amount of providers you should have per specialty based on the population of your service area. You're looking at wait times, how long it takes folks to get into your clinics, your different location, as well as competitor locations and clinics. You're looking not only at the quantitative analysis, but the qualitative analysis, having conversations with key stakeholders in your community, key medical staff, key physicians, key leadership, seeing what their pain points are, seeing what specialties they think are needed in the community, seeing what services they think are crucial to maintain in the community. And you're looking at public health need, understanding, okay, if you have an older population in your rural area that you're serving, are there higher incidences of certain chronic illnesses that need to be addressed? Do you have the specialties to address some of those chronic illnesses? Phase 1 composes what we call a provider needs assessment. And from there, we build out 3 different analyses that, again, are really the pillars of appropriate succession planning. And that's looking at a productivity analysis by specialty, a revenue analysis by specialty, and a provider throughput or encounter analysis by specialty. Through productivity, we're identifying specialties that are, okay, we've got providers that are really productive. There may be a need to recruit here. We have high demand in this specialty and we want to make sure providers are not getting burnt out. You may have specialties where providers aren't as productive. So it's okay. We need to figure out if there's operational barriers going on here and how we can address some of those operational barriers. With revenue, understanding what are your high producing, revenue driving service lines, making sure that you have folks, if they're aging out of that service line in terms of providers and physicians, you have a succession plan in place for those individuals. If you have service lines that have a smaller amount of physicians in them and those folks are getting older, again, making sure you're not losing that service line as a whole, but again, have adequate succession plans in place. And that provider throughput analysis, again, understanding if there's areas for operational improvement. So that composes what we call your provider complement, which makes up your medical staff development plan. In phase 3, we really take it to that next level in provider strategy and incorporate it with an overall system strategy. So it's now, okay, we've outlined in the provider complement who we need to recruit, where we need to retain, where there's potential areas for operational improvement. Now let's look ahead and implement it. So, all right, we've got a 5-year timeline. Who are we recruiting in year 1 and year 2 versus year 3 and year 4? What are we doing for operational improvements in year 1 and year 2 versus year 3 and year 4? Let's look at a compensation overlay. If we want to hire a general surgeon in year 3, let's make sure that's built into the budget in year 3. How do we make sure we can accommodate that new provider in year 3? And finally, a detailed plan. This is the business case on a specialty by specialty basis of why you need to recruit or why there's a need for operational improvement within each specialty. This is really important if you need to talk to leadership or convince a board, or you have a system partner and need to present a business case to a system partner about why you need to go out to the market and recruit. So we talk a lot about operational improvements when we discuss provider strategy. What we like to hone in on is the financial benefits associated with operational improvements and the negative financial effects that can occur if retirements aren't planned for appropriately. It's important for rural critical access hospitals to understand what specialties or service lines are projected to have the largest volume in their service area. Right now, we're seeing a national shift from inpatient to outpatient care. So it's critical for CAUSE to really have an understanding of how they're going to accommodate for that shift, what service lines are going to experience that shift, and what potential service lines are going to have a large volume on the inpatient side. So in this client example, we can see that there is going to be a predicted change of a negative 1.8% decline in discharges in the next 5 years in this service area. When we look at the top inpatient service lines listed here, we see general surgery, cardiology, and pulmonology. And while overall the service area is expected to see a decline in discharges, those 3 service lines are actually predicted to have some growth in inpatient. So it's really important for this client to have providers that can address elements of these specialties or have referral channels in place to have a higher access for their patients to a higher acuity care within some of these specialties. Additionally, we can look at orthopedics. And orthopedics, although it's the 4th largest inpatient service line, it's projected to experience a decline of 12.7% of inpatient discharges in the next 5 years. That's really showing that shift from inpatient to outpatient care. So how can our client position themselves in terms of staffing and providers to make sure they're continuing to capture those orthopedic cases, that market share on the outpatient side, and are adequately shifting from that inpatient to outpatient care sector? Additionally, it's important to identify the service lines that not only will have the largest volumes, but what also are key revenue drivers for the organization. Making sure succession planning is addressed in these revenue producing service lines is really critical. And the example I'd like to point to here from this client is if you look at the orthopedic surgery general line, you'll see that the current FTEs were at 4.9, and the average age of those FTEs is 60. What was really going on is these folks had 4 orthopedic surgeons that were 60 plus. Those 4 orthopedic surgeons alone, not including the work of the APPs, generated 4.8 million in charges for the organization, which equated to about 5.5% of total charges for that organization. So again, God forbid they have 2 of those folks decide to retire in that same year. There goes potentially 50% of the volume within a high revenue key driving service line. So it was really critical for this client to go out and start to recruit orthopedic surgeons to have that succession plan in place. Because again, it can take anywhere from 18 to 24 months to get folks to come to a rural area. 2 other specialties on this list that I want to draw folks' attention to are otolaryngology, or ENT, and urology. In ENT, there's only 1 physician who's age 69. Yes, they're only generating about 0.4% of total charges, but should that physician leave, there no longer are ENT services at this organization. It's really hard to get folks to come back to your organization and restart a specialty once it's gone. So making sure, again, that you have a succession plan in place to address those gaps and critical gaps in access to care is going to be really important. Same with urology, looking at 1.8 current FTEs, average age of 66, drives about 2% of total charges. Again, should one of those providers leave, that's going to leave a big gap in access to care and potentially revenue at the organization. Financial impact of operational improvement versus recruitment. And I think the best way to do this is actually through a case study. So Stroudwater worked with a client whose primary care providers were, the lifeblood of their organization, as it is for many critical access hospitals. Their primary care provider base generated 61% of payments for their critical access hospital. They, at multiple clinics, had wait times of over 6 months for new patients. They had huge demand in their service area. They had no competition in their service area for primary care. If folks didn't go to them, they were going to the emergency room or driving 3 hours outside of the area to go to someone else. So when we were retained, the question was, hey, we know we have a wait list in primary care. We need to know how many folks we need to recruit in primary care and in what clinics they should be based in. But when we dove into the data, we found that of the 29 primary care providers this organization had, only one nurse practitioner was above the 50th percentile for productivity. And this was based on MGMA median work RVUs for rural, non-metropolitan, hospital-owned entities, meaning that all of their other providers were actually underproductive. So it was not a question of who do we need to recruit, but it was there's operational barriers that are going on here that are impacting productivity. Can we immediately start to fix some of those and get more access to care for patients? So Stroudwater said, okay, let's look at the revenue uptick or benefit if we were to increase productivity by 15 to 20%. So if we increase productivity for all providers 15 to 20%, and anyone where the 15 or 20% would put them over the median MGMA value, we benchmarked to median. So no one was associated with being over median productivity. And what we found was that an increase of 15% in productivity was estimated to yield annual returns exceeding 150% of the total yearly compensation cost of an additional physician. So by looking at operational improvements, you could really have a really high revenue benefit as compared to a cost from hiring an additional provider. So we looked at both a 15 and 20% improvement if we looked at 100% established patients, 100% new patients, and a 70-30 blend, where 70% we assumed to be established patients and 30% were new patients. If we were to do that on a 15% productivity improvement, it was generating over $600K annually, and on a 20% productivity improvement, it was generating almost $800K annually. This also equated to, on the 15% side, only 2 additional patients per provider per day. On the 20% side, it was 3 additional patients per provider per day. What I would say here is that upon talking with a lot of medical staff, we found that one of the major barriers was EMR. And this organization was already going to convert to a new EMR in a year and a half. Providers were really struggling with charting. They were spending excess hours really trying to get these notes in, and it was causing them to not be able to see as many patients. So the hope is by doing their conversion to a new EMR, that's going to free up at least an hour or so of more time where they can see additional patients. So again, how can we address some of those operational improvement areas without the need to recruit? This organization doesn't necessarily need to recruit new providers. They need to address operational improvements and then reevaluate if additional recruitments are necessary to address that 6-month backlog of new patients. So then how can you get your providers on board with operational improvements? How do you get everyone on the same bus moving in the same direction? One of the key things to think about is what you can do together right now. What are the barriers that are preventing them from having the patient throughput they need? Are they getting accurate and transparent data on a monthly basis of where they are in productivity and where they need to be? Is there a cadence of conversation with leadership? Do they have monthly conversations with managers and leadership to help understand the data that's being put in front of them? We see a lot of providers exit organizations many times because there's unrealistic expectations as it relates to call burden, as an example. Many providers aren't used to a rural call burden of 1 and 2. Being realistic with expectations of saying to providers, hey, I may not be able to get you a 1 in 3 call burden, but how can I work with you to make this call burden more bearable? How can I help you with this? Is it utilizing an APP as first call, followed by a physician? Does that help address that call burden? You want to work with them and have these conversations. What you don't want to do is have them leave and you're finding out about all of this in an exit interview. So again, engaging with providers on a regular basis about what's realistic and what you can recruit versus not, and where there are areas for operational improvement. How can operational improvement benefit you when it comes to recruitment? Well, number one, providers are expensive. We have to be able to compensate them fairly. It gives providers confidence when you come to them with a business case of, hey, we know these are our volumes within this specialty. This is this is how many patients we expect you to be able to see. This is the ramp up period that we expect with it. Here's the business case that shows you that data and that information. It's also helpful for current providers who can say, all right, my compensation, my volume is not going to be affected by this new recruit because I know we have additional volume that we can capture and that we're not addressing. Again, having that transparency and good data around these expectations is really important. The other big thing that I'd mentioned, I know Kevin will talk about this as well, is being family focused. Being able, if you're recruiting a provider, could you recruit their partner or their spouse, including that whole community in your organization, making sure that family feels a part of your organization only helps with recruitment and retention. And with that, I'll get to our next polling question. Based on your experience, where does your hospital most need focused improvement? Is it operational processes, recruitment and staffing, operations first, then recruitment, recruitment first, then operations, or none of the above? I'll give folks another couple seconds or so to answer those questions. It's pretty split. There's a few that are really split with responses. All right, about 10 more seconds for folks to answer. All right. So we had 34% say recruitment and staffing. We had 30% say operations first, then recruitment. And we had 21% say operational processes, followed by 11% recruitment first, then operations, and 4% none of the above. So let's get to the real meat here. What's the importance of a multi-year provider strategy and how do we implement one effectively? What are the advantages of long-term recruitment? Number one, planning 3 to 5 years in advance allows you to be nimble and take on certain opportunities. For examples, a lot of rural hospitals don't track referral data super well. Planning in advance gives you time to set up appropriate tracking for referral data and look at 3 months out, 6 months out, a year out of what elements, what specialties, what procedures are being referred out of your organization, and if there's anything you can keep local. Are there any gaps in care that you can address with the providers that you already have? Additionally, tapping into emerging talent. Not only who's in the market right now, but who's going to be in the market in the next 2 years. Are there folks that are local to your community that went to your high school and are now in medical school and looking for a job after? Establishing relationships with those individuals, anyone who has connection to your area, can really help reinforce that recruitment mechanism and retain individuals as they feel like they have a job post-graduation, post-passing of their boards to come back to in a community that's ready for them. So what are the advantages of long-term recruitment and how is it a win-win? So long-term recruitment to providers, what are some advantages there? When you're thinking about long-term recruitment and you're going out and speaking with someone who's in a residency program and providing them a clear path forward that's really compelling. Medical school is super expensive, kind of alleviating some of that stress with finding a job after graduation, after passing their boards, allows folks to really focus on their studies, focus on their residency, focus on passing their boards, and focus on becoming the best doctor out there. Again, providing that clear career path gives you security that you're going to have a provider and also gives them security that they're going to have a job. This relationship is only strengthened if the hospital can contribute to loan repayment programs as well. If you're able to do that, that's a great segue and mechanism to help retain providers in your area. Establishing early relationships early on creates a faster onboarding process. You know, if you can do this within 90 days, you get paid faster, but again, you have that relationship moving forward. And finally, and I think this is a big one, you can set a provider up with a mentor or an onboarding buddy so they can transition their patient panel over. If there is succession planning for someone who's thinking about retiring or approaching retirement, getting that new provider on board with culture, having them meet patients, having them understand what it's like to work in rural and have someone they can ask questions to is really important and helps create a sense of security. In terms of the benefit for organizations, it really creates, again, that smoother transition, especially with that onboarding, vetting, and training process. What you're doing there is making sure you're continuing access to care. You're making sure that provider is trained on culture. You're making sure that new provider is establishing a relationship with current staff and other folks that are working at the organization. And this is all huge for patients, as patients can see you are maintaining access, and the community can see that you want this care to continue. And with that, I'll pass it off to Kevin, who'll talk about Mahaska.
Thank you, Claire. Fantastic information, by the way. Great job. Mahaska Health, we're a physician and nurse-led facility just an hour southeast of Des Moines. We have 730 employees and 102 physicians. There's our part of our smiling team right there to the right. Just quickly, a couple items. We've really invested in labor and delivery. We're grateful to have 2 OBGYNs, 2 midwives, 6 family practice with OBs, and then 3 general surgeons that help with C-sections, and they actually get along with each other, which is fantastic. So you can see the growth there. And then general surgery, very thankful for that team who's taking care of so many from a 35 county region. And then we have a full-time tumor board and full-time medical oncologist. And it's really neat to see these patients receiving customized care from an active tumor board. And then lastly, we have a full-time cardiologist with 2 physician assistants and a full staff. And it's humbling to see that we're probably going to do roughly 2,000 echo tests this year, which is really neat to see the care provided for those patients. So with that, this is just a great quote. The number one thing when it comes to change is relationships, right? So how you get somewhere is based on the relationships and the trust that you garner. And that's how you allow a team to be successful. And so it's just been really neat to see our physicians take the lead in how they want to move the hospital forward. And what that has led to is, there's a formula in healthcare that what is value? Okay. That basic formula is quality over cost. But at Mahaska Health, on the top, really our number one priority is our people. And then our people provide a great patient experience. And that's what provides value in healthcare. And what that has led to, Press Ganey implements are not only our patient surveys, but also our employee satisfaction surveys. And year over year, we've been ranked in the 96th percentile, top 100 out of 4,600 healthcare facilities. And it's just humbling to just hear from our employees that they feel supported, they feel listened to, and that they really enjoy taking care of patients at our facility. So with that, a couple strategies, we do have a 10-year recruitment plan. And, the key part of that too is just getting the right people on the bus, right? You want leadership to be supportive. You want physicians to be supportive in succession planning, right? So back in 2018, we made a lot of really good decisions. It was opportunity decisions just to move the facility forward and make sure that we're taking care of regional patients. So we set in tone a new culture. It's a little bit counterintuitive to state that you're physician and nurse led, but we take pride in that. So we have 18 physician medical directors, 3 of which are nurse practitioners as well. And we just had a meeting last night. We meet monthly for 2.5 hours, and we collaborate and talk about how do we take better care of patients and work together across specialties to improve that quality of care. And our administrative team is there, our executive team is there, and we listen and we take their ideas and we turn them into action. And that's really been neat to see. And patients have really benefited from that care. And also, you got to invest in your people, right? So during the pandemic, we had 26 openings, and hospitals around us were furloughing employees, terminating employees, and we did not terminate a single employee. We filled all 26 positions, open positions, with talent from around the region. And then we put a stake in the ground and we gave all 200 of our nurses a $5 an hour increase. It did not make sense for us to pay $200 an hour to a third party company to bring in travel nurses when we could just take care of our own people. And that really was a positive shift in our culture. You got to take care of your greatest asset, which is your people. And then we focused on top line revenue growth, right? So bringing in a full-time medical oncologist and a cardiologist, and we have one of 10 surgical oncologists in the state of Iowa who was tired of the politics and in a larger facility and wanted to join a small critical access hospital. And so we're just thankful for those physicians who are like, hey, we need infectious disease, for example. So we engaged a part-time infectious disease physician who's on call 7 days a week, and he just loves it. So just making sure you help fill those requests, and then that's led to expanding service lines. So 11 hospitals around us have closed labor and delivery, and we want to continue to grow it, but yet be cognizant that we don't burn our employees out. So we're currently recruiting for our third OBGYN, and that's exciting. I actually just had a call with a couple this weekend. Yes, on the weekend. And, this was an OBGYN recruit, and her husband happens to be an endocrinologist. And that would be amazing to have endocrinology at a critical access hospital. And, she's in her residency right now, she finishes next summer. And I stated to her, hey, we would love to have you guys come during a night or weekend just to accommodate your schedule. And she's paused for a bit. And she's like, you mean you would actually host us on a weekend? I said, yeah, the hospital's not 8 to 5 here. And so just being a little bit unique and different and accommodations really makes a difference. And that'll lead to the next slide here. So with that too, a couple of cultural items is we did reverse the organizational chart here. So the board and the executive team, the physician leadership team, we're all at the bottom. And our patients and families are at the top. And that we set that tone back in 2018, and that's made a huge difference. We're all here to serve. And guess what? The more when we serve each other, the better we can serve patients and focus on patients. And then employee goodwill. That's really expanded out to the community. We provide free coffee on Tuesdays and Thursdays. We do food trucks. We free swag to our employees. And guess what? They wear Mahaska Health swag out in the community. And it's good to have that cheer out there. And then creating alignment with the physicians and nurses. We've made it a priority to make it safe to share anything at any time within a meeting. And that's really unique. And so we're thankful for that. And that wasn't always the case, but now we're at a point with our culture that people feel comfortable to do that. So some of the results that have come from this recruitment plan and succession plan, we do succession plan all of our providers as well, is that top employee satisfaction. This is a true story. We were in a call with Press Ganey a couple of years ago, and they said, hey, you guys are not normal. So can you tell us what is going on there? And so that was just a fun discussion that our physicians and nursing staff was able to share with them. Proud of our team. We were awarded top 100 critical access hospital by Chartis Group. And then, yes, the results have led to, we've brought in 85 new providers, which that actually is just so much fun because you get to know their spouses and their families. And it's really created a fun community at our facility. And then, yeah, the record 3 years in a row of the highest top box scores through Press Ganey for patient satisfaction. We just got results this morning. And, to have our ER in the 78th percentile is a big deal for an ER. And then we were awarded 4 centers of excellence. And that's a compliment to our physician leadership for taking the lead in quality metrics. And we're set to be the first critical access hospital to be Commission on Cancer accredited, which is a big deal. And then also the rural transformation funds. That's really that part of that 50 billion that was allocated to rural healthcare. thankfully, Iowa has been procuring those funds, and so we'll get to bring in a brand new PET CT and then use $120,000 each for OBGYN and $120,000 for a general surgery PA. We do have a signed contract for the general surgery PA. She starts here in a couple months, and we're recruiting the OBGYN.
Awesome. Thank you, Kevin. What a success story. That leads us to our third polling question. Does having a long-term recruitment strategy make sense for your organization? Yes, this reflects challenges we are already facing. Yes, but have questions on feasibility and would like to evaluate assistance with a plan. Maybe, may need a shorter term emergency approach. Recruitment's not our top priority right now, or no, this is unrealistic and not necessarily for us. All right. Give folks a few more seconds to answer here as I see we're still getting answers coming in, which is fantastic. Thank you so much. Right. It looks like we've got 60% who have said yes, this reflects challenges we are already facing. 16% yes, but have questions on feasibility and would like to evaluate assistance with a plan. 13% maybe, need a shorter term emergency approach. 9% recruitment's not your top priority, or no, this is unrealistic. For 2%, no, this is unrealistic and not necessary for us. So before we close out today, we wanted to discuss how to necessarily engage with leadership and medical staff around a provider strategy. And so let's start with, how do we engage with providers around operational improvements? The number one thing is to start with the low-hanging fruit. Start with ways you can build trust. You want to establish that relationship, establish that connection. Share data openly, make sure your data is accurate and up to date, and that again, you're having a cadence with these folks on, hey, this is where we want to get to. How do we get there? Where are things that you're seeing that are operational barriers that are in your way from getting there? Additionally, including them at the table to have these conversations and demonstrating to them potential consequences of inaction. What's going to happen if these operational improvements are not addressed? What does that do to the organization overall? Include them in that conversation. Make sure you're listening to them and hearing what they're saying as well. All of this really helps them be involved in the decision making and makes them feel a sense of ownership and alignment. We've found clients have had a lot of success with this by selecting a few physician leaders or provider leaders at their organization who are well respected, well liked, and can really come to the table and participate in these conversations and really, again, to Kevin's point, get folks on the bus moving in the right direction. And I'll let Kevin elaborate on how to engage with providers around recruitment.
Claire, yeah, so there's a couple of strategic initiatives that we implemented at Mahaska Health. Is that I personally make all the phone calls with any new physician or nurse practitioner PA recruit. They want to hear from the CEO or a physician leader that you would have in your facility. And I always accommodate nights and weekends because those individuals are either in training or they're seeing patients, right? And a great way to establish that relationship is via text. And then they're always surprised that, oh gosh, you'll take a call on Saturday evening or something like that. You just make time. And then also, the itinerary is customized to the candidate's background, right? So they might, you always take notes about interests that they have, whether it's, camping or it's something specific that they enjoy for a hobby. You want to customize that. And my executive secretary does a fantastic job of putting a specific agenda together for every single visit. And then also, we deliver on the healthy culture, right? So I communicate the vision, the culture that we have, how we are physician and nurse led. And so they really begin to ask questions, well, why is that, right? And that leads into our physician leaders and why it's so important that we have medical director oversight and that they're leading our committees and administration is there to help support them in their action items. Also, physicians are invited to attend the lunches and dinners, whether it's nights or weekends. And then Before we schedule a time, we make sure that we visit with our own physicians and providers who need to attend, and we accommodate their schedules and work through that because it's so important that they meet their peers that they're going to work with. And that's another piece with the initial phone call is once I make a call and I really like where things are going, I will always have that corresponding physician leader follow up on all the clinical questions that they have. So they have that information prior to an official visit. Also, when they do come on site, we don't shuffle candidates off to HR. I'm there for the entire visit. I personally give them the tour to the entire hospital, and also do any wrap up and follow up. I'm there the entire time. That's the relationship that they need to understand that's going to be built because we hear all the time that candidates are shuffled off to HR, and that's not the person that they're going to be reaching out to when they're employed by the hospital. Also, when those candidates leave, we always send a really nice care package to them. It might be customized about what we hear throughout the visit and followed by a handwritten note. It's just that's the old school way, and people just really appreciate that. Also, again, on-site visits, nights and weekends. We don't ever want somebody to cancel clinics or say, hey, I can't get away from my residency program. We'll always accommodate. Probably one of the biggest pieces and a little bit of our secret sauce is we have providers and physicians who actually like to host students. And that's just a compliment to our team. We host over 200 medical students, high school students, job shadows, and then we also host surgical residents and OBGYN residents. And guess what? If they get exposed to rural practice, they get exposed to our culture, and then we do a luncheon with all these students when the first day they start and then the last day before they leave. And we just talk about their goals and what do you want to do with your future and where would you like to practice. Those relationships have turned into a list of where we have 92 providers on a list. Now, we're not going to hire all 92 of those providers, but if situations change or something happens at our facility, or maybe their spouse wants to move back to Iowa, we have them on a list. And then part of our 10-year recruitment plan is that we send touch points to all 92 providers twice a year, spring and fall. And it's just say, hey, we're thinking of you. Hope your family is doing well. It could be fairy tale brownies. It could be something from Mahaska Health, but it's just a touch point. And a lot of places don't do it, but it really is unique and can set you apart from any other critical access hospital. And then just in ending here, the biggest piece is that of our culture is that our role as in administration is to truly care for the caregiver, right? And then our role is also to re-recruit. And that's where mentorship comes in. And so our physician leaders on the executive team, Dr. Cole Morgan, Dr. Breon, and Dr. Gritters, they put together an entire mentorship program. If that's something that you would love to implement at your facility, we're happy to share that with you. But not only do you want to get them to your facility, but then, gosh, you want to set them up for success. And that's where caring for the caregiver is so important. So thank you all.
So just to touch on the key takeaways from this presentation today. Number one, improving operational processes helps improve recruitment and retention. There are ways that you can be financially benefit, from doing improving operational processes and again, helping shift that culture change at your organization. Understanding your gaps in care via succession planning. Where are you most at risk and in what specialties are you most at risk? Making long-term recruitment a priority, making sure that you have established that multi-year recruitment plan to understand who you need in year 1 and year 2 versus year 3 and year 4, or in Kevin's case, year 9 and year 10. Build a culture of trust, making sure you have that cadence, that communication standpoint, start from the low-hanging fruit and be able to have and host those conversations and sometimes have hard conversations with providers. And as always, engaging with your providers on the process, giving them a seat at the table, and really helping them drive the decisions at the organization. that, I believe we can open it up to questions.
So if you would like, for those of you who are participating in the audience, there is a Q&A box that you can put your comments in. Please put your comments in that section as opposed to the comment section, or your questions in that Q&A box, and we will definitely get them answered. There was one that did come through that asked about what type of a recruitment plan do you have? Or can you explain your recruitment plan, Kevin, for your organization?
Happy to. So we do have a 10-year recruitment plan, which it's threefold. One is, what do we currently want to recruit going forward, right? So currently for us, we're recruiting a second urologist, a third OBGYN, and then a second medical oncologist. So that's kind of that phase one that Claire was talking about, those different phases. So what are your immediate needs? So that goes in the plan. Then the second piece is, okay, how do we succession plan our providers? So, for example, we have a cardiologist who plans to retire in roughly 6 to 7 years. So, what does that look like? Well, we're already talking to one of our hospitalists who's going to be applying for a cardiology fellowship. So, hey, why not be in discussions with him? Our employees and nurses really like him. He's kind to our people and patients. So that's an opportunity where if we didn't have cardiology on a succession plan, we wouldn't be talking to a current PRN hospitalist about succeeding that individual. So that's kind of that phase two. And then phase three is engaging any of your medical students or job shadow students that run through your facility. And then you get to put them on your 10-year recruitment plan and stay in touch with them, right? I don't know how many text messages I've received during Christmas or New Year's when they receive that touch point and they're just like, gosh, thanks for thinking of me. And I'd love to come visit sometime next year. It just didn't work out this year, right? That leads then to a phone call. So that's what is in that 10-year recruitment plan is the current needs, the succession plan needs for the future, and then engaging any students, whether it's a high school kid, a medical student, or a surgical or any type of resident. That's what makes up our 10-year recruitment plan, and hopefully that helps answer your question.
So really playing that long game then.
It's
Yes.
crucial. You don't want to bring on a service line like cardiology or PM&R, and then that physician just retires, and then it takes, like Claire said, 18 to 24 months to backfill.
Mhm. So another question came in on the gift baskets that you're providing to the recruits. Is there a dollar value that you try and keep it under?
Yes, there is. Compliance wise, I think the dollar value has to be under like $223 or something like that. So there is a dollar value. But, fairy tale brownies and there's so many little treats. Harry and David is easy for each provider, is not that much. You figure if you clean up billing and coding, you can utilize a lot of funds for recruitment because that's really that's a whole other story. But gosh, if you can save on the back end and really help yourself in recruiting on the front end, it's well worth it. And just the relationships that come from those gifts it's a lot of fun.
Kevin, I appreciate that plug for revenue cycle because you and I both know that's my passion. But yes, if you do clean that up and work with your team, has done a fabulous job at that, really helped you out with that piece of it.
Right.
Any other questions out there from the audience? I'm not seeing any come through, but just want to say thank you very much, Claire and Kevin, for sharing these practical perspectives on physician succession planning and the long-term strategies that your rural organizations can implement to protect these essential services and financial stability. To the audience, as a reminder, when you exit today's session, you'll receive a brief pop up survey. Your feedback helps us continue shaping the future conference programming, and it should take less than a minute to complete. If you're joining us for our final session of the day, please return to the conference lobby, click on that session from the agenda, and we'll begin at the top of the hour. Our final session today focuses on grant strategy and how rural organizations can strengthen funding opportunities through more intentional planning and storytelling. So look forward to seeing everyone there. Thank you again, Claire and Kevin.
Thank you.
You take care.